Hello, everybody. This is Steve Edelman, and I am excited to talk to all of you folks who have type 2, who have been told you need to go on insulin, or you're already on insulin and you're not doing well and you want to think about the different options. So that's exactly what we're going to talk about. And as soon as I change the slides here we go. So finding the right insulin regimen that fits your lifestyle is extremely important, and we have lots of choices. Okay, so this is a slide I use for doctors, and I wanted you to see what healthcare professionals like myself educate doctors that may not be privy to all the different regimens available for people with type 2. But this slide goes over some general concepts. Number one, don't wait forever. I know that many of you patients push us back. Please, doctor, no, hell no, I don't want the needle. Could we wait till next time? And literally, this could go on at 3 or 4 appointments a year for 3 or 4 years, and you're not doing yourself any favors by avoiding insulin when you really need it. Now, I'm assuming that your doctor has discussed all the other options, all the different oral medications, GLP-1 receptor agonists, and that at this point in time, your control is still not good and we need to do something about it. Okay, address patient concerns and fears. I know it scares the heck out of you. You think that it's gonna cause blindness, it's gonna inconvenience your life, but I think talking to a doctor that's knowledgeable about insulin and addressing your fears is important. And if there's any doctors watching, pay attention to this slide too. Consider combination therapy with oral agents. We're going to talk about that as the first option. That's taking medications during the day, 1 shot of a basal insulin once a day in conjunction with everything else you're using. Now, if you're going to think about the first injectable, start with a basal insulin. If your glucose control is really bad, your A1C is above 9, if it's not really bad, your caregiver should consider using a different injectable first, like a GLP-1 receptor agonist, and titrating the dose is essential. And self-titration can work. That means, what does self-titration mean? With the right instruction, you adjust your own insulin based on your home glucose monitoring results or your continuous glucose monitor. I'm going to talk about that as well. Use a fast-acting insulin analog as an add-on to your basal insulin at mealtime, and this may only be needed once a day with your largest meal. If you have a type 1 like myself, I got to take fast-acting insulin with every meal and every snack because the pathophysiology of type 2 is different. Your pancreas probably secretes a little bit of insulin on its own. Then you may not need to give a fast-acting injection with every meal, maybe just with your largest meal. And can't tell you how important self-monitoring of blood glucose and continuous glucose monitoring. Here's a picture of my Dexcom. Can't really see it that well in the camera. Gives me my blood sugar every 5 minutes. I'm going to talk about that because if you're on 3 or more injections per day, Medicare will pay for your continuous glucose monitor, and even your insurance company, if it's not Medicare, will cover it, but you got to fight sometimes. Now, what about some other general concepts? Type 2 diabetes is a progressive disease. Your therapy may change over time, even if you're doing everything right. You may start off with lifestyle modification and metformin, also called glucophage. Then your caregiver may say, your doctor may say, hey, we need another oral medication, and we may need one of these injectable GLP-1 receptor agonists, Bydureon, Victoza, Trulicity, Ozempic. And of course, we now have Rybelsus, which is a GLP-1 receptor agonist in oral form. Then your doctor may say, in addition to what you're taking now, looks like your morning blood sugars are still too high. We need to add a long-acting basal insulin. And lastly, your caregiver may say to you, I keep saying caregiver, I mean to say doctor or healthcare professional. Caregiver really is your significant other, but who knows, it may be both. That you need to be treated more like a type 1 diabetic where you take a basal insulin and fast acting with each meal. Now, this slide looks at the time action profile of traditional insulins. What do I mean when I say time action profile? It means when do they start to work, when do they peak, and how long do they last? So for example, if you look at NPH insulin, excuse me, I know you said God bless you, so thank you very much. You could see that, right here, it starts to work, a couple hours after you inject it, and then it peaks in 6 to 8 hours, and it lasts only 16 to 18 hours, and you can, or 12 to 18. You can see the graph here on your right. Detamir and glargine are better basals because they're flatter, they last longer, and then you can see rapid acting and the regular insulin. Now, we're going to talk about the newer insulins, and in general, these newer insulins work better. So the first thing I'm going to talk about is the basal insulins. Glargine, which is also called Lantus, has been around a zillion years. We have two new basal insulins. Glargine U300, called TCOYD, and Degludec, also called Tresiba. And I'll use the trade name because that's what you're seeing on commercials and the packages. And don't forget, we got biologic insulins too, like Basaglar. That's very similar to Lantus. And there's another biosimilar made by Mylan, and I don't have the name on this slide, so I apologize for that. Now, here are the two new basal insulin I just mentioned. And why are they better basals? Well, their time action profile is flatter, and they last longer, less peaks and valleys. You don't want that in a basal insulin. You have flexibility of dosing because it lasts 24 hours. You don't have to take it at bedtime. You don't have to take it in the morning. You take it every day at the time that's most convenient for you. Whoops. And lastly, there's less weight gain and less hypoglycemia. That's the one issue with insulin. It causes hypoglycemia and it causes weight gain. But these negative issues with insulin can be minimized with a better basal insulin. So you can see that on the upper part, you can see that TCOYD is pretty flat and it lasts 24 hours, whereas Lantus may have a peak. And importantly, in some individuals, not all, the insulin poops out before the 24-hour period. Look at Tresiba on the bottom, really flat, totally flat. That's what you want. And if you look over on the upper left, the TCOYD max pen holds 900 units, and you can give 150 units at a time. Yes, some patients need that much. And remember, it's not the total amount of insulin you're on, it's what your blood sugars are. So don't get hung up on the total dose. And then the Tresiba Flex Touch. Tresiba also comes in a concentrated form. You can get 600 in a pen, and you can give 160 units at a time. So that's pretty important, and it makes life a lot easier. And if you're using, let's just say, 50 units a day, and you're using the old pen, that's only 3 doses. But if you're using the newer pens, it's a lot more, so it's a lot more convenient too. Let's talk about the fast-acting insulins, the ultra-rapid insulins. So if you look at the upper part, you can see faster-acting aspart, and it's also called FIASP, F-I-A-S-P, or faster-acting Lispro, also called Lumjev. And Lumjev, trust me, Lumjev, these names are so difficult to pronounce. And then they have inhaled insulin, which is Afrezza. So FIASP and Lumjev, they come in a pen, and they also come in vials. So you can give yourself an injection, or if you're on a pump, you can try putting them in your pump, not without your physician's approval. And FIASP and Lumjev, they do work quicker, and they do get out of your system a little faster. And however, Afrezza is inhaled insulin. It doesn't come in a liquid form. And Afrezza does start to work faster, does peak the fastest, and get out of your system faster. So here's the inhaled insulin device. You can see over here, you can see the cartridge. And these cartridges come in 4, 8, and 12 units. You pop it in, you close it, and you can give yourself an inhalation of insulin. Now, the dosing is more complicated than I can get into here. There's lots of good stuff on our website, the TCOYD website, and in the TCOYD book, which you can download for free. If you go into the health fair and go to the TCOYD booth, you can download the ebook completely free. There's a lot of good information on injecting Afrezza. Just remember that 4 units of Afrezza is like 2 units of fast-acting insulin injected subcutaneously. 8 is the same as 4, 12 is the same as 6. So here is the device. You can see it fits in the palm of the hand, and very importantly, you can see rapid on, rapid off activity. So if you follow my pointer in the line with the little clear open circles, you can see it works very fast, it peaks very fast, and very importantly, it gets out of your system very fast. So it's rapid on, rapid off. That's key. Better postprandial control, less delayed hypoglycemia. And that's really important, and Afrezza really meets an unmet need. Now, here's the picture just once again of insulin aspart. It does come in vials too, and then insulin lisocro AABC, not sure what that stands for, but it's Lumjev. And both these insulins are ultra rapid acting insulins that you can take if you're on a multiple daily injection regimen or a pump. But once again, their time course of action is not quite as rapid on, rapid off as Afrezza. Okay, so let's go through now the different insulin treatment regimens. Okay, the first is combination therapy. Oral medications during the day, plus or minus a GLP-1, and a shot of basal insulin. Okay, so this is exactly what it is. Addition of a single injection of a basal insulin to JO, Tresiba, Lantus, Levemir, or NPH once a day to oral medications, and I should say plus or minus a GLP-1 receptor agonist such as Victoza, Bydureon, Trulicity, and Ozempic. So I always have to add those in there because basal insulin works very well with that group. And I'm going to talk about a combination product, 2 of them, where they mixed basal insulin with a GLP-1. Tremendous therapeutic advance. Now, what are some of the benefits of combination therapy? And this is key because you can really make a major dent in your elevated A1C, get it down by adding basal insulin to your current regimen. Typically, we don't stop anything when we add basal insulin. That's typically because if your A1C is high and your fasting blood sugars are high, we don't want to take anything away yet. We don't want to blunt the fall in your A1C. So the benefits are 1 injection a day. It's usually very convenient. You can usually give it in the morning or night. It's a very slow, safe, and simple titration. And I'm going to tell you how to titrate your own basal insulin that you're going to, of course, clear by your doctor before you go off and do anything on your own. You have very little weight gain or very limited weight gain with basal insulin. And it's extremely effective at improving your glucose control. So here's a case, 66-year-old obese female, diagnosed with type 2 diabetes 9 years ago, currently on maximum doses of 3 oral medications. Her primary care doctor started her on 10 units of insulin glargine in the morning. There's going to be a question about this case. Pay attention. Started her on 10 units of insulin glargine in the morning. After 3 months of 10 units of glargine every morning, she felt that it did not work. She stopped it. And her A1C has been above 8.5% for the past 2 years. No improvement, even on 10 units of glargine. Right down below, you can see her SMBG results. That stands for self-monitoring of blood glucose. The morning blood sugars are all high, most of them above 200. Even their bedtime blood sugars are high, 185, 196. So here's the question for you. Which of the following reasons can best explain her failure with basal insulin? A, poor adherence, meaning she's just not taking the insulin. That's an issue in many cases. I'm not sure about this one. B, what's the most likely explanation? This is like a Dr. Board's question. B, initial dose was too low. Should have started off with a much higher dose. C, inadequate titration of the Lantus. This person started on 10, after 3 months came back, was still on 10 units, so that would be a potential explanation. Or D, Lantus should have been given at bedtime. So remember, on board questions, you take the most likely explanation, and in this scenario, answer C, as in cat, is the most likely explanation. When you start off with a low dose of Lantus, that's okay, but you got to titrate it to the dose that brings the morning blood sugars down. And 10 units is typically never the dose that you end up on. It could be poor adherence, that's possible. The initial dose was too low. Well, once again, the initial dose doesn't matter. What matters is if you ratchet it up based on the morning blood sugar. And Lantus could be given in the morning or at night. Now, what about the self-titration? Okay, basically, it's much easier to follow by you, the patient, every day based on a titration regimen where they say, check your morning blood sugar 3 times in a row, 3 days in a row, take the average, and it's just much easier to look every day. So this would be to increase your dose 1 to 2 units every day based on your fasting blood sugar. This example says if your blood sugar is not below 130, you would increase by 1 or 2 units depending on what your doctor says. So you can see the example. And this range is different, that if your blood sugar is less than 100, decrease your dose by 2 units. If it's between 100 and 150, no change. If your morning blood sugar is above 150, increase your dose by 2 units. Now, this regimen is totally flexible. And sometimes you might want to start off with a higher range to avoid any risk of getting low. And you can always change that over time. So here's the sheet we use in our clinic. You can, and whatever the doctor fills out, it's the font in orange. So, and you could use this regimen with any basal insulin. So you can say, start with Toujeo or Tresiba once a day in the morning. Now, why do I like the morning? The morning is good because you wake up, you check your blood sugar, you look at the sheet, you adjust your insulin dose, or you make no change, depending on what the number is, and then that's it, and you give yourself the injection. Now, if you give your insulin at night, that's fine, but you have to somehow still test your blood sugar in the morning and find a way to go back and find what that result was when you take your insulin at night. If you're on NPH insulin, and you might be, because it's super cheap and you can't afford the newer insulins, NPH always, and I mean always, has to be given at bedtime. So with NPH, it works pretty good, but you have to take it at bedtime, not at dinner, not in the morning. So you can see number 2, start with 20 units. Number 3 there, every day, every single day, you check your blood sugar in the morning. In this example, if you're above 140, you increase by 2. If you decrease, if you're below 90, you subtract 2. If you're between 90 and 140, then you keep the dose the same. If you can't test, just use the dose you used the day before. Don't be guessing and going up on your dose without having documentation that your blood sugar was too high. And 2 units a day is pretty good. Think about it. In 7 days, and if your blood sugars are through the roof, you will increase your dose by 14 units. And eventually it'll start to come down. So remember that increasing your dose until your morning blood sugar levels at goal is extremely important. Most patients will need 40 to 70 units a day. Some patients need more. Some patients need less. The total dose does not matter. So what matters is what happens to your morning blood sugar. And we've shown this time after time again in excellent research studies. If you can bring your morning blood sugar down to near normal, 120, 130, the rest of your numbers throughout the day will get better and your A1C will come down. So now, the second time they attempted this in this patient, they switched to TJO. They started with 10 units again at night. They titrated up to 120 units a day. And you can see that the pre-breakfast numbers now come down to between 90 and 140. The A1C, which was above 8.5, dropped to 6.9%. No hypoglycemia and 2-pound weight gain. That's a small price to pay to improve your blood sugars tremendously. And typically we don't change the oral medication. Every once in a while, if a patient is on a sulfonylurea, glipizide, glyburide, Amaryl, these are drugs that can cause hypoglycemia. Every once in a while, if the blood sugars start getting too low, then we withdraw those type of pills, or we at least cut it in half. Now, I talked about the first pitfall, titrating way too slowly. What's the second big pitfall? And believe it or not, there's only two. And that is not paying attention to your bedtime glucose values. And so I suggest start performing paired testing. What does that mean? Test at night and again the next morning. So Friday night and then Saturday morning. You want to see what the basal insulin is doing to your bedtime blood sugar. So remember that if your blood sugar at night is always 200 and the next morning it's 200, it means your basal dose is set correctly. You've got to do other measures to bring your blood sugar down to a much better level at bedtime, i.e. between 140 and 180. And that's what's important. And a lot of times, if you don't look at the bedtime blood sugar and you keep going up on your basal insulin because your morning is high, then you might get into a situation where you are ready for this word, basalinizing yourself, giving yourself too much basal insulin to fight off that high bedtime blood sugar. Hopefully I can make this clear, because what will happen is if you give yourself too much basal insulin because you're not paying attention to your bedtime blood sugars, then all of a sudden you're going to go to bed with a good blood sugar because you ate a lot less for dinner or you exercise, and you're going to crash overnight. So remember that your bedtime blood sugar should be between 140 and 180. And if you're wearing a CGM with the trend arrow straight across, and then if your morning blood sugars are good, you're there. If they're not there, you can safely raise your basal insulin. So remember, getting paired testing is key. And once again, I want to say this again, if your blood sugar is 200 going to bed and it's 200 in the morning, it means your basal insulin did a perfect job. You want your morning blood sugar to be about the same level as your bedtime. But since your bedtime blood sugar is 200, you need to do something else between dinner and bedtime to improve that number. Okay, I talked about this a little bit earlier. These are fixed combinations of a GLP-1 receptor agonist like Victoza, with the case of Zoltify, and with the case of Soliqua, it's lixisenatide. So there's liraglutide, lixisenatide. The chemical names always end in tide. And these are ratios, a fixed ratio combination, and you basically give it once a day. They typically want to have you give it in the morning, just like we like to give you basal insulin, and you titrate it just like you titrate basal insulin alone. Now, because these combinations have a GLP-1 receptor agonist component to it, like liraglutide, like lixisenatide, you get away with using much less insulin. Your blood sugars come down quite dramatically, and it's a very effective way to control your diabetes. You're using two drugs with two different mechanisms of action mixed together in the same pen. So this is, you can read about Zoltify and Soliqua in the TCOYD book that once again you can get free in the exhibit hall. Okay, let's go to the second type of insulin regimen. Now, what is this one? This is still looking at folks that are on oral medications plus or minus a GLP-1, and all you add is a fast-acting insulin to the biggest meal. Okay, so that could be breakfast, lunch, dinner. So it's just adding in one more injection. And I can show you a picture here of a typical regimen. And here's a patient who is on, you can see the gray area is their own endogenous insulin, how much insulin their pancreas can secrete. And then you would give either a Afrezza, Apidra, Humalog, Novolog, Lumjed, Fias. These are all fast-acting insulins. And based on home glucose monitoring with a glucose meter, or if you're lucky enough to have a continuous glucose monitor like Dexcom or the Libre 2, then you are able to see what meal drives your blood sugars up the most. Some people just guess, but I do suggest that you do paired testing once again. Not so much bedtime and the next morning. How about 6 p.m. when you're eating dinner, and then 8 p.m. 2 hours after eating. And if your blood sugar after eating is through the roof, that might be the time of the day to try a single injection of a rapid-acting insulin or ultra rapid-acting insulin. Now, in this scenario, it's most likely that your body is secreting some insulin on its own. Remember, when you have type 2 diabetes, it's not like type 1 where we don't secrete any insulin. A lot of times people with type 2 still secrete their own insulin, and you may get away with 1 shot a day. Now, I would say that regimen I just told you about, the second bullet point, probably not used very much, because most practitioners are using basal insulin first, then they add on a fast-acting insulin. We're going to get to that in the 4th bullet point. But first, I want to talk about pre-mixed insulin given twice a day. We also call it the split mix regimen. And typically, we use these insulins that you see on my slide. Humalog Mix 75-25 or Humulin 70-30, Novolog Mix 70-30 or Novolin 70-30. What does the 70-30 mean? What does the 75-25 mean? It means that of this premixed insulin, 75% of Humalog Mix 75-25 is the intermediate acting insulin, NPH. So Novolin 70-30 is 70% NPH, 30% regular insulin. And you typically give it with the 2 biggest meals of the day, typically breakfast and typically dinner. Now, here are the issues with this regimen. You can see there's no coverage at lunch. You do have some NPH that you took with breakfast, having a mild peak. But if you have a large lunch, it's not going to help cover that meal. The NPH is peaking that you take at night between 2 and 4 a.m. And that can sometimes lead to nocturnal hypoglycemia. So if you eat dinner at 6 p.m., it's going to be peaking at 2 to 4 a.m., and that could cause a low blood sugar. And that NPH is pooping out. It's losing activity before you wake up in the morning, and you could wake up with a high blood sugar. And there's not much flexibility with this insulin regimen. You take it with breakfast and dinner, and you can't adjust the dose too much because you're adjusting an insulin that has both rapid-acting, fast-acting, and intermediate-acting insulin. And NPH is quite honestly not the best basal insulin. Now, saying that, I do have patients on this pre-mixed insulin twice a day, and they seem to do pretty well. And the folks that do well are the folks that are creatures of habit. They have breakfast at the same time, they have dinner at the same time, and I've asked them to try to eat a lighter lunch because you're not taking any insulin. And if you have a lunch that has a lot of carbs in it, then your post-lunch blood sugar will be elevated, which means that it'll carry over to your dinner time. So I tell them, try to have a light lunch. Have a salad, avoid carbs at lunch. Save that for the breakfast and dinner where you're taking rapid-acting insulin. Okay, let's talk about the second most common insulin regimen next to the most common, which is combination therapy, basal insulin in the morning or at night. And basal bolus regimen or an insulin pump. So here's a patient who is on oral agents and a basal insulin. And you can see that his post-dinner blood sugar is elevated. And right where the arrow is where he is having dinner. And this is the time period where you'd say, hey, I think this patient needs one insulin injection at dinner time. The rest of the day is not doing too badly. You can see that his median goal of 154, he's there most of the day. He's a little bit lower at night, but he bounces up after dinner. So you might say, okay, let's take the oral medications. You might be on a GLP-1. You're already on basal. Your morning blood sugar is already titrated so that you can't go any further with the basal insulin because you'll get low in the morning. This person needs a shot of prandial insulin at dinner time. So this is sort of the approach that we teach doctors who take care of patients with type 2 diabetes that may need insulin. Well, step one is basal insulin. And you try to get that A1C less than 7. You try to get your fasting less than 130. If you can't do it, you go to the next stage, which is add a fast-acting insulin analog or inhaled insulin with a main meal. Could be breakfast, could be dinner, could be lunchtime. And you wait a couple months. If the A1C is still not below 7 and the fasting is still not less than 130, then you add a second injection with a second meal of the day. And then if that doesn't work and you're still not reaching your goal, then you need to go to a full, what we call basal bolus regimen. You take a basal insulin once a day, and then you take fast acting with each meal. And it really depends on how long you've had type 2, how much your pancreas can secrete, and typically the longer the duration of type 2 diabetes, the more likely that you would need fast-acting insulin with every meal. Now, what about pumps? Pumps are not only for us folks with type 1. Here's a gentleman cooking dinner on the grill. You can see right behind his shirt is an Omnipod. And you can see that right there. Here is an Omnipod. Before you put it on, it comes with a little syringe and a needle. Here's the pod. You fill it up with fast-acting insulin, and you put it on with like a Band-Aid. You pull off the little stickies. You can see in the white area. You stick it on. You take your controller. In this case, you can see the Omnipod dash. It insert the catheter for you with a needle. The needle withdraws back into the Omnipod, and you're good for 80 hours, a little over 3 days. There's the Tandem Control IQ or the Tandem Basal IQ. It's an excellent pump. It's got a touch screen. It's more of a traditional pump with tubing. And with both of these pumps, you could use it with, in conjunction with a continuous glucose monitor. So you can see here, this is the Dexcom. I almost pointed with my finger on the screen. You can't see that. You can see my arrow right here. You can see there's the Omnipod. I'm sorry, there's the Dexcom sensor. The data goes to the insulin pump right there. And then you can see with the Omnipod dash, you can definitely download your CGM data, but it doesn't quite connect yet, but it will as soon as the new Omnipod 5 or the Horizon program comes out. So what are some of the safety concerns with insulin? But let me just say one more thing. Remember that if you're on multiple daily injections, an insulin pump could really be what you need. So you don't have to get out a pen and give yourself an injection 5-6 times a day. You get out your Omnipod dash controller. You can, based on if you're just correcting your blood sugar or giving yourself insulin before meals. Same with the Tandem pump. You can just program in. And from that point, it makes it really easy. And so insulin pumps are not just for people with type 1. Now, what about safety concerns? Hypoglycemia or low blood sugar is a concern for anybody taking insulin. And If you're taking Afrezza, you might develop a cough, but it's not very common. So it's important to know to read as much as you can about Afrezza before you start it. And of course, Afrezza is not for smokers, anybody with lung disease, anybody with COPD, and there's a simple test of your lungs you need to get before starting, and it's 6 months and then yearly. It's called the FEV1, Forced Expiratory Volume 1. You can do it with a little device in the office, and you can do it in a regular lab. Now, every person with type 2 diabetes on insulin or a sulfonylurea like glipizide, glyburide, Amaryl, these are medications that can cause your blood sugar to get too low, should have emergency glucagon kit. Every patient. And make sure it's not expired. Why? Because you can get a severe hypoglycemic reaction where you pass out, you have a seizure, and that's extremely important. These are the old kits. You got to be a chemist to use this thing. You have to inject the diluting fluid right where my arrow is. Whoops. You have to inject this diluting fluid into the little vial. You have to shake it up, suck it back out, and then inject it in someone. And that may not be fun, especially when your loved one is doing the fried egg. They're having a seizure. So these were important kits for many years. Novo makes them, Lilly makes them, but now we have two much better options. Now, as someone living with diabetes, typically you're not giving yourself glucagon, you get some juice, but you may need to give yourself these agents if you think you're dropping so fast you can't consume enough sugar and food to prevent your blood sugar from getting so low that you're having a seizure. There's Baqsimi made by Lilly. It's nasal glucagon. You put that I'm pointing over there, like you should be looking. The little yellow nasal tip into your nostril, you spray it. Now, you wouldn't be doing it yourself normally. Your loved one, you'd be on the ground going, I'm so low, I can't swallow anything. Remember, don't let anybody shove anything in your mouth when you're so out of it, because it'll go in your lungs, it'll aspirate, and you'll have pneumonia, aspiration pneumonia. That's not good. So typically these emergency glucagon formulations are given to you by someone that is trying to help you. Gvoke, the hypo pen, you look on the right, it's just like an EpiPen. You pull off the red thing and you hold down on your skin, it auto injects. You don't have to mix either, so it's pre-mixed glucagon. The days of mixing glucagon with a liquid are over. Anybody who's watching this video that's a type 2 on insulin or a sulfonylurea, you need to have an unexpired glucagon pen at home, and you need to teach your loved ones how to use it. Now, I talked about continuous glucose monitoring for type 2s. No more pricks. We hate pricks. The typical CGM systems, they have a glucose sensor inserted under the skin, measures your glucose every 5 minutes. It's a wireless transmitter, and it sends it to a receiver, either a smartphone or what I had up earlier is a monitor. My blood sugar is 81, and very importantly, the trend arrow is straight across. So here is the Dexcom G6. I just got to 80, and it gave me my little warning, so I can get something to eat the minute I finish this lecture. So that's the G6. You can get it on the monitor. You can see a picture. You can get it on your smartphone, and you can get it on an Apple Watch. And there's the Libre 2. That's the 14-day sensor. You can see it on the back of his arm. And this young lady has the back of her arm for the Dexcom. And it gives you a blood sugar every 5 minutes. And you can put in your own upper and lower limits with both CGM devices. Once again, if you're on 3 or more injections, Medicare will pay for it, and most insurance companies will pay for it when you're on injections. So remember that when you have a glucose meter, you just know what your blood sugar is at one point in time. When you're on a CGM, you see it at 24/7. Now, if you look at the blood sugar levels in these patients, the black line, you're going high, you're going low, you're all over the place. compared to the folks that are in the green 3 labeled line, those folks have the same A1C. Remember, the A1C is an average. It doesn't tell you how much fluctuation you're getting. So this is probably a good example. You have a glucose meter, the blood sugar says 220, but you don't know if it's going, you don't know what direction you're coming from, you don't know what direction you're going to. So here you see 220 with 2 arrows up. And in this picture, you're 220 with 2 arrows down. In the upper scenario, you're gonna go for a walk, you're gonna take fast-acting insulin, you're gonna try to give yourself a correction dose. And if it's at mealtime, you're gonna take more than you would normally give if you were just 220 with a static value. On the lower scenario, listen, you're gonna keep an eye on that. You're gonna go get some glucose and make sure you have some with you. And if it's mealtime, you're gonna take a lot less or just wait. So the other thing about insulin is, and by the way, there's a great chapter in the TCOYD book, chapter 10, that you can get for free in the health fair on how to deal with trend arrows and manage your diabetes. Okay, truth or myth? Insulin can cause weight gain. Well, it's true, but there are different ways that you can deal with this. So first of all, insulin is associated with weight gain. You typically a small amount. Remember that you want to avoid hypoglycemia, and typically you will gain weight with insulin because you will have, if you treat your blood sugars and you're bringing them down from a higher level, that you will lower the amount of sugar that you're peeing out in your urine. So that's why people gain weight when their blood sugars get under good control. And sometimes insulin could lead to fluid retention, and that'll cause weight gain. And if you're not eating the right things for hypoglycemia, then you can overtreat yourself, meaning that, let's say you get low a lot and you eat a ton of Skittles, cupcakes, Oreos, and you're not just giving yourself, 4 to 6 ounces of juice, then you can gain weight from all the things you're eating to treat your low blood sugars. And once again, these better basal insulins and rapid acting insulins, they'll help you avoid hypoglycemia. The better basals are flat, and the ultra rapid, they work quickly and they get out of your system quickly, and they have less delayed hypoglycemia. So basically, we're getting to the end of my talk. And I say take the 30-day challenge. If you've been resisting insulin for your doctor, I would say try it for 30 days. If the injections are too painful, or if your blood sugar do not improve, or you do not feel better, that your A1C is down, and you can stop it. So that's what I say to patients, and they say, oh, really? I can stop it? I go, yeah. And I can tell you what, if you're on a good insulin regimen, you'll feel better with your improved control, and you're gonna say, shoot, what was I pushing back so long for? So remember, please go to our blog and ask as many questions as you like on our TCOYD website. I will answer every single question you have. Thanks for listening, and I hope you guys take control of your diabetes. You owe it to yourself and your family members.